All right, we'll record a message, and some of the lecture for today, guys. Today is 1/19/2021. We are finishing up the RT210C, which is Pulmonary A&P. Pulmonary A&P's lecture. We will ask a few oral practice questions today from the oral exam, and we'll talk about some of the homework that was given out. You had a nice little amount of weekend. I hope everybody stayed safe. So a couple of things I want to put out there. If you have missed an exam, tomorrow is the last day to make up your exam. If you have an exam out there that you're missing, you didn't do it for whatever reason, you're not in the hospital, then tomorrow is your last day at 6 o'clock. So tomorrow after the class in the lab is complete, I will log in for those who need to take whatever test. If you didn't take test A or if you didn't take test B, when you log in, you can take that test. Okay, now I will allow it virtual for those that have the COVID or whatever issue that you can't come and you're in quarantine. If you happen to be in quarantine and I have documentation to prove that, not just because I had a fever, so I'm in quarantine, that doesn't work. Okay, if you have some kind of documentation that says why you can't be at campus for that sickness or whatever, then and you're in quarantine, then I'll let you take it virtual tomorrow. If not, you need to be here after class and take it. Okay. Now, if you are a 1 to 3 student and you have a test you need to make up, I'll let you take it when you get done with your lab. I'm not gonna make you come back at 6. You did the 1 to 3, and I'll let you take it after class and after the exam for tomorrow is done in the lab. Then I'll let you take your test if you got one that you missed. Okay. But bottom line is tomorrow is the last day. If you don't get it done by tomorrow, it's a 0 for an exam. Actually, you actually have 5 days to take a test. So if you missed an exam, you actually have about 5 days. So I'll make sure I count those days, but I'm pretty sure that we've gotten to that point. Okay. A lot of times we let you go a little bit above and beyond. Hello. Hey, what's up? No, I'm at work, son. All right. Yeah, so I'll let you go over sometimes, but we got to start tightening down. All right. Another tightening down thing, and that's by the policy. Another thing is the homeworks. I get a lot of different people saying, well, I didn't get this one, or I didn't know this, or didn't know that. And just so it's clear, if you are in quarantine, that does not excuse you from doing the homework or studying. Okay. Studying, watching the lecture, doing the homework, submitting assignments. The only thing that's different when you're in quarantine is, of course, is taking the test up here in person. Of course, you can't come, right? But that's the only thing that's different. All right. If you're in quarantine at home, then you need to be still watching the lectures, taking the notes, and turning in the homework. There's no compromise on that. All right. As of today, I have not taken off on anybody's homework as far as points. If you didn't do a certain assignment, you might not have gotten attendance for that day, but I didn't strike you down for homework. Everybody in here still has 100% on all the homework A and homework B. Okay. And homework C is, the last one I will give today is today. All right. Starting with RT210D and beyond. If you miss an assignment, a homework assignment, you don't turn it in by the deadline, that's points taken off. All right. I've already explained that for each module, you have 100% already for your homework. So if there are 4 homeworks, just for example, say RT210D has 4 homeworks, okay? And you only do 2 of them throughout that module when I give them, then your homework grade for 210D is a 50%, okay? If it's 4 of them, that means there's 25. If you miss 2, then that's a 50, okay? If you do all 4 of them, you keep your 100. If you only do 1, you have a 25%. If you do 3 of them, you have a 75%. So you see how this is going, okay? So it's very important that you turn those in because those homework grades can keep you could be the very little points you need to push you over to 75 to go on to 220. All right. So make sure you do those. Now that's starting with RT 210D. All right. As of now, everybody still has 100% for A and B and so far C. Okay. Now that talks about the last day to take tests and then the homework grades. The next thing I want to reiterate is tomorrow. Alpha students are 1 to 3, and my Omega students are 4 to 6. We can modify that a bit. I have my second dose of the corona vaccine tomorrow. I have to be there at the hospital at 12:30. So there's no guarantee that I'm going to be right back here by 1. So Alpha students, come at 2, all right? Because it's only going to take you 30 minutes to take the test, and tomorrow is the hand washing lab. That's going to take 5 minutes, and you're done. Okay, so just come at 2 if you're an Alpha student. 2 to about 3, right? 30 minutes for the washing, and then 30 minutes for the lab. Okay, Alpha students 2 to 3. Omega students, you can come in at start coming in around 3. All right, I don't mind, because by the time the first group is leaving, the other student coming in, that's fine. If you want to get it over with early, you can come in around 3 and take your test, and you'll be here from about 3 to about 4, okay, or 4:30 at the least. Now, if you can't come until 4 because you already have your job situation, then that's fine. I'm not going anywhere. Okay, I'll be here till everybody's complete. So if you have to come at 4 to 6, then that's fine with me. Okay, I'm not going to say you just can't, you just missed it. All right, I'm not going to do that. But if you want to knock it out early, you can. All right. So again, Alpha students, don't come until 2 o'clock because I might not be here. I'm going to be taking my second vaccine. All right. Lord willing, I'll be all right after the vaccine, but I'm going to take that second vaccine and then come here. All right. So that's how we'll do that. And the last thing before the lecture is pop quizzes. I'm finding that, and we've talked about it, that a lot of students are not getting the full effect of 210 because there are no quizzes or anything that's holding you accountable other than tests. Okay. And so when you take your test, you memorize whatever you need to memorize. Some students just memorize and then take the test. Sometimes I'll go over sample test questions and you're memorizing these test questions, and then because they're getting on to the next levels and not retaining the information. And the reason why you're not retaining is because there's a lot, students are not retaining is because a lot of it's being done by memory. And you memorize, but you don't know how to you memorize A and B, but you don't know how to put A and B together. Okay. And that's because there's no extra going in and being accountable for other information. Okay. So pop quizzes will be spread out throughout now and the rest of the term.
I'm not going to be able to do these.
Do what? Say what?
Oh, my apology. I didn't know it was off mute.
Oh, okay, no problem. So the pop quizzes will be spread out. Okay, you'll have 3 to 5 quizzes from here to the end of the term. Okay, and of course it's a pop quiz, so you won't know. But the pop quizzes are comprehensive in nature. A lot of students are not going back and looking at the previous modules. That's very important. You cannot forget about cardiac A&P just because we're in pulmonary right now. All right. You may have a pulmonary exam that has 6 cardiac A&P test questions on it. So if you totally disregard A and focus on just C, or B and focus on C, then you're not going to get the meshing of it when it's time to move on. Okay. And that's why a lot of students bomb the final, because the final has everything, but because they memorized A, B, C so good that when they got to that point, the final didn't keep them from moving forward. Okay. They were able to move forward, but barely. And then when they get to these other levels, they're not able to comprehend it and put it together. All right. So these quizzes, when I give you, I say pop quiz, it'll be on Canvas. You'll go to it and take it. You'll have like this first one I got, not today, but when I do it, it's 12 minutes. All right. So it will be virtual because I don't know when everybody's going to be here, but it will be virtual. And you only have 12 minutes to complete it. So it won't be like you have like a minute a question or a minute and a half a question. It's like 10 questions or 8 questions, something like that. And you won't have time to look up everything because they spread out A, B, and C. Okay. And so that means when you're looking and you'll get out of class, go back and study the other modules, watch videos, lectures, whatever you need to do, read, look at your notes, because it's important that you're able to put all of the stuff that you've learned together. Okay. And that is going to be a way to make sure it forces the student to go into the book, like the workbook that I gave. The workbook work that I gave, chapter 9, forced you to go into the book to find those answers. All right, because it really goes right along with the book, but it makes you go along. And so that gets you in the process of reading and studying the Egan's book and going deeper than just the lecture. Okay, we have to be accountable of what we're putting out there. Okay, it's a lot of students, so everybody has to tighten up your boots and be accountable, because it's not like we have 6 people and I can really guide each student. But since we have 20 students and it's online, it's hard for me to do that. So you have to be accountable. Okay, so those will be going forward, and that's it. So let's get started with the lecture. Still only have 13 students that are live, so I mean, it is what it is. All right, let me share my screen. Question. Mm-mm. Anytime between now and the end of this term. Okay, anytime. All right, I'll already have it in there, and then I will say, okay, guys, everybody go to the module and look in the pop quiz. Okay. The pop quiz will be. Yeah. Depending on when I give it, but like I said, it's comprehensive in nature, so it's going to be complete. It's going to comprise of everything, but it won't be, if you haven't finished the lecture for D, then I'm not going to give you questions on the pop quiz that's got stuff you haven't covered yet. Okay. Yes. The way I'm grading the pop quiz is that, you know how you've got A, B, C, D homework grades? Well, K is a homework grade as well, but K is CPR. There is no homework assigned for K. Okay. So what I'm going to use in the spot of K is an average of your quizzes. So say we have 5 quizzes and you have 100 on every last quiz. Then for your RT210K homework grade, it'll be 100. But if you get a 10 on the one and then you get a 50 on one and a 40 on the other one, right? And I average that grade, that's going to be your homework grade for K, whatever your average for your quizzes are. All right. So that means take it serious, because it is going to affect your grade. All right, here's the lesson plan. We left off yesterday or Thursday. It's been so long. Let me make it a little bigger. We left off yesterday with, or Thursday, we talked about the muscles of ventilation. I hope that you got a lot out of that workbook pages. They're really, really good. I hadn't been using them that much because we were on campus and I had a lot of worksheets I could pass out and we could be doing classwork. But since we don't have that luxury of being on campus as much, then we'll start using that workbook a little bit more. And it's very, very good at keeping the students' nose in that book, because that's where a lot of information comes. And then it also helps you understand what you've learned in lecture, because you may read something that I didn't say, okay, but you're still responsible for it because it's in the reading. All right. And so we left off talking about the muscles of ventilation, which is diagrammed and outlined well in the book. And so we talked about the diaphragm. We talked about the accessory muscles. Then we stopped at types of breathing. Now, this is where we're going to talk about the different breathing patterns. There are different types of breathing patterns that are noted and seen throughout the hospital. Different reasons, different issues can cause students, or not students, but patients to breathe differently, okay? So this is the types. This is, make sure you understand this terminology, because when we talk about breathing patterns, we're going to be talking about in these terms and not just he was breathing fast, right? Normal breathing. When somebody is experiencing normal breathing, that's considered to be eupnea. Number one, eupnea. Eupnea is normal breathing at a respiratory rate of 12 to 20 breaths per minute. And not only are they 12 to 20, but they are normal and consistent. They're not real big, deep breaths or not real shallow breaths, right? Eupnea is not only 12 to 20 breaths per minute, but it's consistent and regular, right? When somebody's just breathing consistent and regular, that's eupnea. Because if somebody was breathing 12 to 20 breaths per minute, but then stopped for a minute and it started again, that wouldn't be eupnea. That'd be something else. If they're having periods of apnea in between, that's something else. So you need to know it's more than just 20 breathing a normal rate, but also consistent and regular. Hyperventilation. Hyperventilation is when somebody is rapid and or deep breathing, right? Deep and fast, or breathing real, real fast, or really, really deep. Now, make sure you understand that there is a difference between hyperventilation and tachypnea, okay? Tachypnea, as you'll see down here, is a respiratory rate greater than 20. Okay, he's tachypnic. But if he's breathing deep and fast, then he's hyperventilating, because it's a difference between just breathing fast. The tachypnea is really the speed, and hyperventilation pertains to what? What would hyperventilation pertain to?
How fast he's pushing the air out?
Not fast. The tachypnea would be the speed.
How deep his breaths are.
It's deep, but it's something else I'm looking for. Ventilation. What is ventilation? No. Think of your AKAs. Think of your AKAs when we talk about ventilation. Think of your AKAs when we talk about ventilation. CO2. CO2. When somebody's blowing off too much CO2, that's hyperventilation. Blowing off too much CO2. You got to make sure you know that ventilation is CO2. It is respiratory. It is an acid, right? It is capnia, and it's also carbia. Don't forget those AKAs. So when I say somebody's tachypnic, I'm just saying that he's breathing faster than 20, right? His respiratory rate is like 25, 26. That's tachypnic. Okay, he's a bit tachypnic. But if he's starting to blow off too much CO2, now he's hyperventilating. Okay, his ventilation is the movement of CO2. Okay, CO2 is ventilation. All right, number 3 is hypoventilation. That's not the same as bradypnea. Bradypnea is a respiratory rate less than 12. Okay, if he's breathing less than 12, that's bradypnea. Okay, now it can also mean he's hypoventilating. He's going to start hypoventilating if he doesn't pick it up. Okay, because as soon as he goes a little bit less than 12, he's all right. But if he sustains bradypnea, will turn into hypoventilation, because his CO2 is going to start what? If he's hypoventilating, then his CO2 is
building up.
Building up. It's building up, because we exhale CO2, right? And if we're barely breathing, then the CO2 level in your body is becoming higher and higher and higher. And so that means the body is becoming what? What's another AKA for hypoventilation or ventilation? His body's becoming what? Acid. Acidotic, because CO2 is a what? Acid. So if you're building up acid, his body and his pH is becoming acidotic. his blood is becoming acidosis. Respiratory acidosis. Why is it respiratory? Because it's ventilation. It's CO2. CO2 is ventilation. It is respiratory. It is an acid. Okay, that's why I gave that to you early. Make sure you say that to yourself so you can get that understanding. Okay, because when we get to acid-base chemistry, you're going to have to know this. All right. Now, so hypoventilation. Hypoventilation is slow or shallow breathing because, and what it's doing, it is building up CO2 because you're not blowing off enough. So I even write it right here. Not blowing off. All right, that makes it better. So hyperventilation is rapid, deep breathing that leads to blowing off too much CO2. Now they're hyperventilating. That is why your panic patient passes out. All right. When somebody starts, oh my God, and start doing all that, they pass out. Why do they pass out? Because they blew off too much CO2. If CO2 level drops below a certain level, you fall out. All right. That's why we put a plastic bag over their face so that it catches some of the CO2 that they're blowing out, so they don't blow off too much. That's what I mean. Paper. That's what I meant to say. Paper bag. That's all right. That's fine. Questions are always welcome. That's what I meant to say. Paper bag. A lot of people will put a paper bag or brown paper sack or something over somebody's face if they are hyperventilating because they're blowing off too much CO2. And you're trying to catch some of that and make them rebreathe it so they don't fall out. Okay. And then hypoventilation, guys, is when I'm shallow breathing, right, or very slow, and I'm not blowing off enough carbon dioxide, which leads to respiratory failure because of the buildup of acid. That's respiratory acidosis, or also known as respiratory failure. Your body is failing to ventilate, right? You have to get the CO2 off, guys, or you're going to go into respiratory failure. So the patients who die of overdose, they don't die because of the drug. They die from respiratory failure because they get so sedated that their respiratory rate gets shallow and low, and CO2 starts building up to a point where the body cannot live because it becomes too acidic and it dies. Okay? If you hold your breath.
Mr. McCarthy.
Yeah.
I'm sorry, I was just going to ask, so is it the Cpap machine
The what?
that pulls off the carbon, the Cpap machine, like what people wear at night to go to sleep?
Now the CPAP machine opens up the airway. When you fall asleep, your airway collapses for some people. Obstructive sleep apnea, when you're breathing, air is going, in and out your lungs, right? But then when you fall asleep, those muscles relax and they close. And every time they close, the body wakes up, all right? It's waking you up every time. You might not wake completely up, but you're waking up. Because as soon as you become conscious again, it opens back up. So you fall asleep, it closes, the oxygen starts dropping, the body wakes you out of the deep sleep, and you open back up. So when we do CPAP, that's a continuous positive airway pressure. That's what CPAP stands for, continuous positive airway pressure. So it's just a continuous pressure that's being blown through the airway. So when you fall asleep and those muscles relax, they can't close. They have to stay open because there's pressure in there. That's air that I'm blowing in there the whole time. Therefore, they don't wake up 100 times a night and they get sleep. Okay. for people who are sleep apnea, they're tired during the day because they're waking up 100 times a night, whether they're waking all the way up on the side of the bed or their body is waking up. Eyes can be closed and you can be awake, okay? That's all it takes is for the body to wake you up just enough to wake them muscles back up again. And then as you fall into a deep REM sleep, they close again and wake up, close again, oxygen drop, wake up, close again, oxygen drop, wake up. And that's all night long. But if we put the right amount of pressure in the airway, then you cannot close. And therefore they don't wake up and they get good sleep. Okay? So that's why we use the CPAP. All right. Now, what else did I say about CO2? It's also capnia and carbia. Okay. So if CO2 is carbia, then hypercarbia is a high CO2. If CO2 is also known as capnia, then then hypercapnia would be what?
High CO2.
CO2. Okay. Capnia, carbia. Go get your AKA sheet out. Get your AKA sheet out about the CO2 so we can make sure we understand how these terms coincide with each other. I'm gonna write it on the board. All right. So CO2, aka acid, aka ventilation, aka respiratory, aka carbia, and aka capnia. CO2, and these are all of your also known as, right? All right. Now, let's look at this. If I hyper,
what's that last C word? I can't see it. What's that?
That's capnia.
No, the one before it. I'm sorry.
Carbia.
Okay, thank you.
RBIA, carbia, like carbon. All right, so if I hyperventilate, if I'm hyperventilating, then I have a low what? CO2. And then if I hypoventilate, it's going to give me a high CO2. Everybody understand that? If I hyperventilate, I'm blowing off too much CO2, so my CO2 is going to get low. If I hypoventilate, that means I'm not blowing off enough. I'm bleeding shallow and slow, right? And if I'm doing that, I'm building up CO2.
Hey, can you lower that a little bit? I can't see it.
Hey, let me move it up here on this other thing right quick. That better?
Yes, thank you.
Problem. So if I'm hyperventilating, I'm blowing off too much volume, which is going to give me a low what? Carbon dioxide. Okay? If I'm hypoventilating, That means I'm barely breathing. And if I'm barely breathing, that means I'm not releasing enough CO2, and it's going to start to build up. Okay? So knowing this, I want you to tell me what this equals. I want you to focus on these two terms, carbia and capnia. Focus on carbia and capnia. This is what I want you to answer the question in, carbia or capnia. First, let's talk about capnia. We're going to talk about capnia, okay? Answer this question. Hypoventilation equals what? Capnia. Hypoventilation equals what type of capnia?
Hypercapnia.
Hyper. What's hyper mean? More than normal, right? Hypercapnia. See that? Hypoventilation leads to hypercapnia because hypoventilation, I'm not blowing off enough. Hypoventilate, higher CO2. Hyper means high, right? Hypo means low. So if I'm talking in terms of capnia, hypoventilation will lead to hypercapnia. Got it? What about this? Hyperventilation equals what type of capnia? Hypocapnia. See it? That's why you got to have them AKAs down pat. You got to, so you'll know what they mean. Because all this is saying is high CO2, low CO2, because capnia is CO2. What about carbia? Now let's look at carbia. It's going to be the same thing, but just got to be able to say it. If I was talking about carbia, because you never know what the word is going to say on the test. You never know what they're going to use for that old CO2. They could use acid. They could use carbia, capnia, ventilation, respiratory. They could use any of that. You got to know that they all mean carbon dioxide. So hypoventilation will equal what type of carbia?
Hypercarbia.
So hypercarbia means a lot of carbia, a lot of carbon. If you're not breathing, you're going to be building CO2. What about hyperventilation? Somebody blowing real deep and hard. What's going to be the word? Hypocarbia. Okay? Carbon dioxide is the single most important thing in a respiratory therapist's career. That is your bread and butter. And remember, ventilation is different than what?
Oxygenation.
Thank you. It's not the same thing. I can't fix hypercarbia but throwing oxygen at it. That ain't gonna do nothing. I can't fix hypocarbia by throwing oxygen at it. You don't fix a ventilation problem with oxygen. You can't do that. You don't fix an oxygenation problem with ventilation. Okay, in a roundabout way you could, but what I'm saying is they're two different animals. Okay, you fix oxygen problems with oxygen. You fix ventilation problems with more volume or less volume. Okay, if somebody has, let's see here. Let's do one more aspect of it, and then we're going to take a break. This is the normal CO2. The partial pressure of arterial CO2 is 35 to 45 millimeters of mercury. That is the normal value for carbon dioxide. Now that's what you definitely need to memorize. The partial pressure of carbon dioxide in the artery is 35 to 45 millimeters of mercury. All right, so I want you to see this. Anything greater than 45 is very, very acidic. Because CO2 is an acid. But if it's more than 45, you're going into acidosis. Okay? Acidosis. And anything less than 35 is losing its flavor, right? It's losing its acidity and becoming alkaline. So anything less than 35 is becoming alkalosis. That is the normal. 35 to 45. So I'm going to ask you a question. If somebody is, are you ready for the question? I don't want you to just tell me less than or greater than, okay? If somebody is, let's go with hypoventilation. If somebody is hypoventilating, I expect to see their PaCO2 to be what?
Greater than
Greater
45?
than. So PaCO2 greater than what? 45. Excellent. If they're hypoventilating, they're not blowing off enough what? CO2. And it's rising and it's becoming greater than 45. Because that's the normal range. 35 to 45, that's normal. Anything greater than 45 is becoming very, very acid and they are hypoventilating. Anything less than 35 is when they're about to pass out because they're blowing off too much and they're hyperventilating. Okay? So you know that hypoventilation is a CO2 greater than 45 and a hyperventilation would be what? A PaCO2 what? Less than 35. Right? Now I'm going to throw you a curveball. Make sure I'm going to let you get that right quick. Make sure you see that. If they're hypoventilating, they're not blowing off enough CO2 and it has risen above 45 millimeters of mercury. Thus, the blood is becoming very what? Very acidic. If the person is hyperventilating, their CO2 level has dropped below 35 and the blood is becoming alkalotic. Alkalotic. Okay? Somebody trying to get Brittany. You trying to get in? What's your last name? Okay, I thought Brittany was in there. Okay. All right, here you go, Brittany. Now, so now that we know that, I'm going to ask you a question and we're going to go to break. This is one question I'm going to ask. All right. I want you to know the term, either carbia or capnia. I want you to use either one of those. It's fine, okay? If I have a PaCO2 of 52 millimeters of mercury, what would this term be called in terms of capnia? I want you to write it in the chat. Don't nobody say it out loud. Write it in the chat personally to me. The question is, if I have a PaCO2 blood level of 52 millimeters of mercury, what would that term be called in terms of capnia? Write that in the chat. If I have a CO2 of 52, what would that be? What would the term would you call that in terms of capnia? Write it in the chat. I'm gonna answer that in a minute, then we're gonna take a break. Do I have anybody saying anything? Oh, a lot of people already said, okay. Looking good. Talisha, look at it again, baby. The answer is, if they have a PaCO2 of 52, that means their CO2 is higher than normal, and a high CO2 happens because of hypoventilation. So hypoventilation, ventilation being capnia, would be hypocapnia. See how they come together? Hypocapnia. This person is hypocapnic. Hypocapnic. I'm sorry. My bad. But see how I'm just testing it. Yeah, I was wondering why y'all was looking all dead and in gloom. No wonder. My bad. My bad, Casey and Kelsey. My bad. Hypercapnia. The reason why, because I think somebody put that, and that's what was on my mind. That's why I said, look at it again. Talisha, look at it again. I knew what I was saying. I just said it the wrong thing.
I was really confused.
Yeah, I messed him up and he bust me out. So go ahead.
Listen though, if the CO2 is 52, that means their number is higher than 45. So that's a high CO2, right? A high CO2 means hypercapnia. Hyper, because capnia is CO2. So if it's a high CO2, it's hypercapnia. The person is hypercapnic. All right, now what if their CO2 was 10? Somebody has a CO2 of 10 millimeters of mercury. What would that be in the terms of capnia? Hypocapnic. There would be hypocapnic. They're hypocapnic. And what, and this is what probably threw me off. What is causing the hypocapnia? And what's that called? Hyperventilation. Hypocapnia is caused by what, Cassidy? I can't hear you, Cassidy. You're muted.
There we go. What was the question?
I said, if somebody is hypocapnic because their CO2 is 10, and you guys said that means they are hypocapnic, which means they low CO2. I said, Cassidy, what causes hypocapnia?
Like shallow breathing.
What causes hypocapnia, a low CO2?
Oh, you're not breathing in enough CO2.
No.
Or not pushing out. Something like that.
Hyperventilation. Look, hyperventilation causes a low CO2. Hypocapnia means low CO2. So what causes hypocapnia? Hyperventilation. If the CO2 was 60, you guys said it was what? 60 was what
Hyper.
kind of hypercapnia if it's 60, right? So Michael, if the CO2 is 60, that's a lot, right? It's more than 45, so it's a high CO2. That's hypercapnia because capnia means CO2. But Michael, what's the question is, what causes hypercapnia?
Hyperventilation or hypoventilation.
There you go, hypoventilation. That means they're not blowing off enough. So if you're not blowing off enough, it's starting to build up. Okay? Hypercapnia is caused by hypoventilation. Hypercapnia is caused by hypoventilation. Okay? And hypocapnia is caused by hyperventilation. Okay? So if I see a patient breathing really deep and fast, I'm assuming his CO2 is dropping. Okay? He's becoming very hypocarbic or very hypocapnic, right? All right. Or even what? Alkaline. His blood is becoming alkaline because that's synonymous with a low CO2. Okay, take a break. 55 after. Come back at 10 after. We went a little hard. Come back at 2:10. We're going to take a break till 2:10 and continue on with the types of breathing and how they pertain to ventilation. All right, we're back. It is now 10 after. Now, this question I have for you now. This is the next question. What is, if I have a PaCO2 of 40 millimeters of mercury, then what would that term be called? No. Huh? It will.
Isn't it pronounced like Eupina? Eupina?
There you go. Eupnea. Eupnea.
Okay.
Eupnea is what? Normal breathing. Remember, we just learned that eupnea means normal breathing. The normal breathing pattern is considered to be eupnea. If somebody is experiencing eupnea, then you expect their CO2 to be normal, right? 40 is right smack down in the middle. 40 millimeters of mercury is a perfect CO2. Perfect. That's what you're looking for when you get an ABG on a patient and you look at the CO2 value. You're looking for this range, but perfect would be 40. Okay, perfect. So that, guys, is how you need to be able to relate CO2 as it pertains to ventilation, as it pertains to respiratory, capnia, carbia, hyperventilation, or hypoventilation. Okay, hypoventilation causes a higher CO2, which is hypercapnia, hypercarbia, or somebody's becoming very acidotic, right? If somebody's hyperventilating, they're blowing off too much CO2 and they become hypocarbic, hypocapnic, or very alkalosis. Alkalosis. Okay? All right. Let's move right along. All right, dyspnea, number 4. Dyspnea is somebody who's having labored or difficulty breathing, also known as shortness of breath, SOB, right? If somebody says I'm short of breath, you see that they're struggling, and what would they be using to let you know that they're experiencing shortness of breath? Accessory muscles. You'll start to see the sternocleidomastoid mastoid muscle picking up. They'll be tripoding and leaning on stuff, right? They're showing you signs of difficulty breathing, which is dyspnea. Dyspnea, okay? So if you saw a question that said patient, you walked into a patient's room and they had their elbows up on the bedside table, they were using their accessory muscles, stomach and stuff was retracting, then you, if they said, what would that be? You would say dyspnea, right? They're experiencing dyspnea. And then of course, apnea, which is with the A in front, A means without, that means they're not breathing at all. If somebody is apneic, they are not breathing. That's why we say sleep apnea is when they stop breathing in sleep, whether it's central or obstructive. You'll learn later that sleep apnea can be central, which is just a brain telling you, not telling you to breathe, right? Or it could be obstructive, where there's actual obstruction of skin that's stopping you from breathing. Whichever way it goes, you're stopping breathing while asleep. So stopping breathing is apnea. Okay, apnea. All right, the next one is called, these next couple ones, guys, are different types of diseases that cause these problems, or some type of injury or damage to the brain or body or heart can cause these problems. Biops. Biops breathing is several short, deep breaths followed by a long period of apnea. Okay? So biops, several little short breaths, and then a long period of apnea, and then several short breaths, apnea. Several short breaths, apnea. It's textbook. That's called Biops breathing. What causes Biops breathing? It can be caused by brain damage or increased intracranial pressures. ICP stands for intracranial pressure. That's pressure inside of the brain, inside of the skull, right? Inside of the cranium. If there's an injury, patient has a car wreck, has a traumatic brain injury, the brain starts to swell. When it starts to swell, it's pressure, right? Because the skull does not give, right? Just like a wall. And so as the brain starts to swell inside your cranium, pressure increases. And that can cause Biops breathing. Nothing you can do to fix it. There's nothing you can do to fix Biops breathing except for change the pressure in the head, okay? The brain damage. If you can fix the brain damage, you'll fix that breathing pattern. So Biops breathing looks like this. It's breathe, 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 stop. Breathe, breathe. Little short one, not big breaths, just breathe, 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 stop. Breathe, 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 stop. Breathe, 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 stop. That would be Biops breathing. Biops breathing. Remember what causes it. All right, the next one is called Cheyne-Stokes. Cheyne-Stokes, some people say Cheyne-Stokes, either one. Cheyne-Stokes breathing pattern. Cheyne-Stokes breathing pattern is a increasing and decreasing in depth and rate, followed by periods of apnea. So it's not just breathe, 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 stop. It's short breaths, big breaths, short breaths, stop. Short breaths, big breaths, short breaths, stop. Short breaths, big breaths, short breaths, stop. See that? It's the difference in it's increasing and decreasing depth and rate of your breathing, and then followed by periods of apnea. That's called Cheyne-Stokes breathing pattern. Now, Cheyne-Stokes, which is, I forgot their names, Chatham, Cheyne, and something Stokes, came up with it, and they put it together. But it's caused by congestive heart failure, decreased blood flow to the respiratory center, and brain damage. Caused by congestive heart failure, decreased blood flow to the respiratory center, and brain damage. All those things can cause Cheyne-Stokes breathing pattern. All right. Next one is Kussmaul's. Kussmaul's breathing. Now, this is somebody who has deep gasping respirations. Just deep gas, just continuous. You're like, when are you going to fall out? Because you got to be about to fall out the way they breathe. Okay? Deep, continuous gasps of breaths. And that's caused by diabetic acidosis. Diabetic acidosis. You're going to learn that's a metabolism problem, a metabolic problem. CO2 is respiratory and the bicarb is metabolic. Remember I said metabolic, aka base, aka alkalosis, right? That's the other end of the spectrum, right? And whenever you have a diabetic problem, you start to build up lactic acid in your body, your legs, all it becomes a lot of acid in the body, the tissues, right? Down in the tissue layer. And that can cause Kussmaul's breathing. And what's happening with Kussmaul's is because the body senses a large amount of acid, right? It's saying your legs and your body, your metabolism is full of lactic acid. There's acid all over in your tissue. So the body's only response to get rid of acid is to do what? Breathe it out. That's its response to acid, because CO2 also is a acid, right? So the body just knows there's acid there. So how do I get rid of acid? I should start breathing hard. And that's why they go into this breathing pattern, because of the high levels of acid from diabetic acidosis. So somebody who's in a diabetic crisis or something like that, or in a diabetic coma, they're probably breathing like this. And that's when the bicarb becomes really, really low, because bicarb is a base. And if a lot of bicarb, you're very, very alkaline. But if you barely have any base, it turns into acid. Okay? And so a really, really low bicarb level, person will go into metabolic acidosis, which is indicative or can happen because of the diabetic acidosis. Okay? And then 9 and 10 is just a simple form, right? It's not as in depth as we just learned about hyper and hypoventilation. Now you see the difference. Okay, tachypnea just means somebody breathing more than 20 times. That don't necessarily mean he's blowing off too much CO2, right? Could be cool for him. He just, bottom line is breathing more than 20, okay? It's not hard to do. That's not a lot, okay? But more than 20 is tachypnea, and less than 12 is bradypnea. Only when we start talking about CO2 and all of that, when we get into the difference between those and hyper and hypoventilation, okay? So that's why I broke those down for you, so you can really see the difference between the two. Tachypnea means their respiratory rate is more than 20. The normal rate is 12 to 20. 21 is considered tachypnea. Okay, so you see that's just one more breath. So that doesn't necessarily mean that hyperventilating just because he's breathing 1 over the normal limit. Just means he's breathing 1 over the normal limit. So now he's considered to be tachypnic. All right. And if he's breathing 1 less than 12, then that's considered to be bradypnea. Okay, bradypnea. I keep thinking I got my mouse. All right. Now, what regulates the breathing? And this is the last part of the lesson. But the regulation of breathing, well, we still got to talk about breath sounds, but the regulation of breathing, what in the body is regulating all this? How does the body know to breathe more? When does it know to breathe more or breathe less, right? Where at in the brain are these things being signaled, okay? And that's what we're going to talk about now. What regulates your breathing? who's responsible for keeping your CO2 in the normal range? That's the basic goal, is to keep it normal, right? The body starts sensing a little bit more, it'll make you breathe more, right? So it'll bring it down some. If it starts to sense that it's not enough, it's going to slow the breathing down some, right? So it can build back up a little bit. It's trying to keep that in normal range, all right? So where are we? Let's look at it. The Medullary Respiratory Center. The first part of the regulation of breathing is the Medullary Respiratory Center. The Medullary Respiratory Center consists of the medulla. Oblongata. I think that's the rest of it. The medulla is the lowest part of the brain stem. Okay, the medulla. Let me see if I got my. I ain't got my book. Hold on one second. I'm gonna see if I got this PowerPoint. All right, the Medullary Respiratory Center. This is the medulla down here. The medulla is the lowest part of the brain stem, okay? Down here, down in this area is your medulla, okay? Then you have the pons, will be up in here, okay? This is your pons. And then this is the Medullary Respiratory Center, which is the medulla, all this bottom part, okay? In that you have the dorsal respiratory group. Why does it dorsal? What's dorsal mean?
Across.
No, that's lateral.
Along the
back.
The back.
Towards
Good.
the back.
Towards the back. Because like the dorsal fin of a shark is the one on his back, the one closest to the vertebrae, right? So this will be the dorsal. The dorsal, and then of course the front one is called the what? The ventral, because it's the one across closest to the belly surface or closer to that surface, right? So you have the dorsal respiratory group that has a job, and you have the ventral respiratory group that has a job. And then you have this pre-Bolitzer complex. We don't really talk about that much, so don't worry about that. But you do need to see that there's a dorsal and a ventral respiratory group that make up the medullary center, okay? And then the Pons center, or Pons respiratory center, has the pneumotaxic center, right? Pneumotaxic center and the apneustic center. All these little centers are firing to each other, okay? They fire to each other and they cause us to ventilate, all right? Some of the centers in the brain will respond to a low oxygen, and some of them respond to low CO2, okay? And you'll learn, I think those come in a little bit later, so I don't want to go too far with it, okay? So you see this right here. I'm going to come back to the notes and talk about each one. This is what it looks like. This is where all the magic is telling you, or all the, let's say, the electrical fireworks are coming from here to tell you what to do as far as breathing is concerned. Now, we do know that the diaphragm is the most major muscle of ventilation, correct? All right. What did we say? Nerve that comes from the brain that goes all the way down to the diaphragm. What? In the chat, don't reel it out. In the chat, tell me what nerve comes from the brain to the diaphragm that makes it descend and ascend. Put it in the chat. Good, Christian. Good, Charisma, Stephanie. Kelsey? What is the name of that old nerve that innervates? The word is called innervates or stimulates, okay? The nerve that stimulates or innervates the diaphragm is called the, good Cassidy, Maria, Michaelin, good. Heather, good. The phrenic nerve. The phrenic, P-H-R-E-N-I-C, the phrenic nerve. That is the main nerve that goes from your brain down to your diaphragm and tells it to descend. When the diaphragm, which is a dome shape, right? When the diaphragm descends or flattens, it sucks those lungs open and they fill up with air, right? Because the pressure inside of the chest becomes lower than the ambient pressure. And that forces air from outside to come in. Because we said gas and volume run away from what?
Pressure.
Gas, good. Gas and fluids, they run away from pressure. So if the pressure is lower in the lungs than it is outside, it's going to run from outside and come into the lungs. Because the diaphragm flattened out, sucked those lungs open like a vacuum. Remember I told you, put a balloon in your mouth backwards and suck like that. Your mouth, the pressure inside your mouth becomes real negative and that balloon is going to fill up in your mouth. That's what's happening in your lungs. That's how they fill up, okay? Because when that intrapleural pressure, right? The pressure between the pleura, which is the visceral pleural and the parietal pleural, that intrapleural pressure becomes negative, really, really low, right? And so if the ambient pressure, when ambient means outside, if the ambient pressure is higher than the intrapleural pressure, then the gas has to run away from the higher pressure. So comes right into the lungs, right? And then when you're ready to exhale, the diaphragm ascends, comes back up, pushes the lungs back up, and they, since they're elastic, they recoil, right? The pressure inside the lungs then becomes more positive than outside, and gas has to run away from the lungs and right back out, okay? That is the whole process of the ventilation, okay? That's the process of the ventilation. Runs away from pressure, okay? Runs away from pressure. All right. Let me see if that's up here. Yeah. Now, that what I just told you about, that's coming when we get into pulmonary mechanics about the changes in pressure. It's going to ask you, what is the pressure at resting intrapulmonary pressure? What is the pressure ambient and why does it move? So you don't have to know that for this test, okay? But I'm showing you that's what's coming, all right? But that is definitely what happens for that makes ventilation happen, okay? I just want to make sure it wasn't in here. All right, let's go back to where we were. Okay. So back to the medulla. The medulla, which is the lowest part of the brainstem, it contains widely dispersed respiratory neurons. The medulla has the dorsal respiratory group and the ventral respiratory group. The medulla respiratory center, or the medullary respiratory center, has the dorsal respiratory group and the ventral respiratory group. Now, Michaelin, tell us what the dorsal respiratory groups do.
The dorsal group mainly inspire neurons. So it sends impulses to the diaphragm and external intercostal muscles.
Good. So the dorsal respiratory groups are mainly made up of inspiratory neurons. So they mainly focus on inspiration, right? So they send signals to everything that's got to do with inspiration, right? And we said the diaphragm, of course, got to get his, right? He's the main thing of all ventilation. And then why the intercostal muscles?
Because they move the ribs.
Good. So the intercostals help with what?
ventilation. No, oxygenation
No,
and
no, no.
ventilation.
Hold on. You have two sets of intercostals, right? We said we have external intercostals and internal intercostals. So now, what I want you to tell me now, listen up. This is one of those critical thinking things. We learned what the external intercostals do and what the internal intercostals do. So if the dorsal respiratory group is mainly inspiratory focused, right? It's the neurons that are mainly focused on inspiration, all right? In the chat, I want you to tell me which one of the intercostals does the dorsal respiratory group send a signal to? Which one of the intercostals does the dorsal respiratory group send a signal to? Put it in the chat. Please don't say it out loud. Put it in the chat privately to me now. Since the dorsal respiratory group is focusing mainly on inspiration, and we know that the intercostals help with inspiration and expiration, right? But there are certain ones. Which intercostal muscle will the dorsal respiratory groups send a signal to, since they are mainly focused on inspiration? Put it in the chat. Good, Stephanie. Good, Michaelin. I'll call your name if it's right. Somebody's iPhone. I don't know whoever iPhone is. That's correct. What you say? Your last name is Williams. No, I don't see Williams. Are you iPhone? Did you put an answer in? Okay, then you probably are iPhone. Yeah, I see you coming in. So Michaelin is right. Williams is right. Kelsey is correct. Christian is correct. Stephanie is correct. You put an answer in, Lori? Let me see, Lori. No, the ribs are the bones. The intercostal muscles are the muscles in between the costals. Costals mean rib. So the muscles in between the ribs are intercostal muscles. You got two sets, external and internal intercostals. So my question is, the dorsal respiratory group that focuses mainly on inspiration would send signals to the diaphragm and the intercostals. But I'm asking which intercostals would they be mainly sending signals to? All right, good, Heather. Good, Shatara. Christian's right. Kelsey, Michaelin. All right. So the answer is, and Charisma, I'm not looking for the location of the intercostals, but I'm looking for which particular intercostal would it send to. All right. The answer is the external intercostals. If you put external, you are correct, because the external intercostal muscles aid with inspiration, and the internal intercostal muscles aid with expiration. Remember I told you they were opposite. Excellent. So now the dorsal respiratory group, they're only focused on inspiration. They focus on getting you to inspire. So they're sending signals out to the diaphragm and then to the the external intercostal muscles. All right. The next group of medullary respiratory center is the ventral respiratory group. Now, the ventral respiratory group, they contain both inspiratory and expiratory neurons. Okay, they have both. The ventral has both expiratory and inspiratory neurons. Now they're going to talk about each one. The ventral respiratory group has both inspiratory and expiratory neurons. Now the inspiratory neurons, you got it, Shatara? The inspiratory neurons will abduct the vocal cords, increase the diameter of the glottis, innervate the diaphragm and external intercostals. That's what's happening for the inspiratory neurons of the ventral group. The ventral respiratory group does a few things, right? It has both inspiratory neurons and expiratory neurons. First, we're going to talk about what the inspiratory neurons of the ventral group does. They abduct the vocal cords. That means they widen out the vocal cords, right? They make the vocal cords become wider, right? Which increases the diameter of the glottis. What do we say the glottis is? No, it's the hole between the vocal cords, right? The hole between the vocal cords. So this is what's happening with the inspiratory neurons of the ventral respiratory group. All right. Okay, so the ventral respiratory group has both, right? Inspiratory neurons and expiratory neurons. Now, we're going to talk about the inspiratory neurons of the ventral respiratory group. First thing it does is abduct the vocal cord. So these are the same. These will be your vocal cords. Right? So the inspiratory neurons of the ventral group will do this. They abduct the vocal cords, which means they widen out the vocal cords. So they make the vocal cords wider, right? They abduct the vocal cords, making the vocal cords come out, separate a little bit more, right? Which then will increase the diameter of the what? What is this hole called?
Glottis.
Glottis. So since the vocal cords have been abducted, right? Now that makes the hole to the glottis bigger, okay? Just like your lips. If they're closed and I abduct your lips, I open your lips up, which makes your mouth bigger, right? Okay. So they abduct the vocal cords, therefore increasing the diameter of the glottis. Okay? What else does it do? It said it also innervates the diaphragm and external intercostals, right? And we already know what specific inspiratory nerve that interfaces that diaphragm is what?
Phrenic nerve.
The phrenic.
The phrenic nerve that we just talked about. So the ventral respiratory group, right? The ventral has inspiratory and expiratory neurons, okay? The inspiratory neurons will abduct the vocal cords, make the glottis bigger, right? And send signals to the diaphragm and external intercostals for inspiration, okay? And one of those nerves that it uses that's connected to the diaphragm is the phrenic nerve, okay? That's the three things it does. And that is so if you don't have it, that's the ventral respiratory group. And the groups we're talking about now are the medullary center. The medullary respiratory center has two groups, the dorsal group and the ventral group. Right? The dorsal group and the ventral group. We said the dorsal group only focuses on inspiration, right? Inspiration. They send signals down to that diaphragm and external intercostal muscles. Then we said the ventral group has both inspiratory and expiratory neurons. And we said the inspiratory neurons will abduct the vocal cords, open up that glottis diameter, and innervate the diaphragm and external intercostals. All right. But not only does it have that, it also has expiratory neurons. So let's see what the expiratory neurons do. The expiratory neurons of the ventral respiratory group will send signals to the internal intercostals and abdominal expiratory muscles, right? Because we said the abdominal muscles are used for what? The abdominals, the stomach muscles. No, they're not accessory. They're used for forceful.
Oxygenation.
No, not oxygenation. All of it's for oxygenation. All of it will
Forceful
help.
ventilation.
Say it again.
Forceful ventilation.
Forceful exhalation.
Oh, exhalation.
There you go. So when you blow out the candles on your birthday, you're using your abdominal muscles, right? Especially if you're old as I am. You're going to need to cock up and strengthen up them abdominals to blow all them candles out, right? So forceful exhalation is your abdominal muscles. So when you are, the expiratory neurons will send signals to the internal intercostal muscles, which help with expiration, and also send signals down to the abdominal muscles just in case you need to forcefully exhale. Okay. All right. So that is the medullary respiratory center. No, that's what makes up the medullary respiratory in the medulla. The medulla oblongata. Right. All this is going on. You got dorsal groups and ventral groups. Okay. Now we'll talk about the Pontine respiratory centers. Pontine respiratory centers. Why disappear? The Pontine respiratory centers. Just let me share my screen so I don't have to switch up so much. Can y'all see the PowerPoint now?
Yeah.
Yeah.
Coming up now? Yep. Shatara, you can't see yours? Okay. Okay, that's okay. So we just talked about the medullary respiratory center. See it right here? Let me go to full screen. The medullary respiratory center consists of the dorsal respiratory group and the ventral respiratory group. We said the dorsal respiratory group focuses mainly on inspiration only, and the ventral respiratory group focuses on inspiration and expiration, right? All right. Now, what about the Pons respiratory center? The Pons respiratory center consists of the pneumotaxic center, which is this one, and the apneustic center, which is this one. See how amazing your body is? These little bitty pieces of meat, right? These little bitty structures in the brain do all of this breathing for you. They regulate your breathing. All this is to keep pH in the normal range, okay? The number one goal, guys, of ventilation, not only is to make sure CO2 is right, but the whole number one reason why we do this is the whole goal is to regulate pH, okay? Write that down. Bless you. The number one goal for ventilation is to regulate pH. We want our body's pH to be perfect, because if the pH is out of whack, you can't do anything, okay? If my pH is too high or too low, I cannot metabolize any medicines that they give me. I could give you medicine IV, but it'll come in and go right back out. It will never get processed or metabolized if the pH is not right. So if pH is not working, nothing's working. Number one goal for ventilation is to regulate pH. Okay, because we said CO2 is an acid. So if the CO2 gets really high, we become acidotic and the pH becomes acid. That ain't regular, right? So we have to manage it with the way we ventilate, okay? If the CO2 is too high, we need to ventilate more, right? We need to hyperventilate them so that they can bring that CO2 down. If their CO2 is really, really low, then they're already hyperventilating. We need to hypoventilate them so it can start building back up. And we want it to be within that normal range of 35 to 45, right? But that is a direct reason why we do it, is to make sure that the pH stays normal, okay? All right, so let's look at the Pons Respiratory Center and see what all consists of the Pons. All right, can y'all see the lesson plan now? Okay, I'll start doing that because it's easier for me to share that way. All right, the Pontine Respiratory Center. The Pons is located above the medulla on the brainstem. We saw that. It consists of two different centers, apneustic center and pneumotaxic center. The apneustic center sends signals to promote a prolonged, unrestrained inspiration. The apneustic center sends signals to promote a prolonged, unrestrained inspiration. Now, Kelsey, what do you think that is, Kelsey? What would be a unrestrained, prolonged inspiration? Give me an example. You with me, Kelsey?
Yeah.
Okay. Just think about it. What?
The Shane Stokes.
No, I'm not looking for a breathing pattern. I'm just talking about something normal, something you do every day. The apneustic center allows you to do what?
Can I answer it?
I'm gonna give her another moment.
It promotes a
Prolonged, unrestrained inspiration. What would that be?
unrestrained inspiration.
Yeah, so what would that be for you, Kelsey? What's an example of that?
Like if you were exercising? No.
Not really. Michaelin, what was you gonna say?
A yawn?
A yawn. A yawn or a sigh breath. You know how you, right? A sigh breath or to yawn. A yawn is not a regular inspiration, right? It's a prolonged, unrestrained. It lets you get a good old yawn out. That's what the apneustic center allows you to do. A prolonged, unrestrained inspiration. All right. And then it also has vagal and pneumotaxic center impulses hold the stimulatory effect in check. Okay, so the apneustic center will send signals to let you take a deep breath, but the vagal or the pneumotaxic center will keep it in check. Okay, it ain't gonna let you just keep on till you pop, right? The reason why you stop inspiring when you take a yawn, what if you just kept yawning like that for 5 minutes? You would blow up, right? So the pneumotaxic center keeps it in check. It'll say, all right, that's enough. Right? You're taking a good old yawn, and then the pneumotaxic center will cut that yawn off. It will stop the inspiration because that's enough. You don't want to pop, right? And there's, you're going to learn that there's, how does the pneumotaxic center do that? How does it know when it's too much? We're going to learn that, all right? But the pneumotaxic part of the apneustic center will hold the stimulatory effect in check. So in a sense, look at number 3. The pneumotaxic center controls what? Inspiratory time.
Does it control like a cough?
A cough is expiratory. You know, you take a deep breath in and cough. That's your abdominal muscles that'll help you cough. Okay. But the pneumotactic center controls the inspiratory time. So if you want to take a yawn, you can't take a 50-minute yawn, right? If you keep on yawning like that, you will pop. So the body has to have checks and balances, right? That's what the checks and holds it in check. The pneumotactic center holds it in check. So you think about taxes. Taxes keep you in check, right? Come out your check. Do taxes come out your check? All right, so the pneumotactic center keeps the inspiration in check. Okay, that's how you can remember it. If you want to help you remember it, the pneumotactic center controls inspiratory time. It keeps the inspiration in check. You can't go too far with this. You know what I'm saying? It was, you know, don't overdo it, body. So it's telling itself, don't overdo it. I'm gonna stop you right there. It also has strong signals that increase the respiratory rate. So not only is it controlling the inspiratory time as far as shortening it, but it can prolong it too. It controls the time, whether it's fast or slow. It controls the inspiratory time, okay? Whether it's high, fast or slow, or long or short, it controls it. So they have strong signals that come from the pneumotactic center that will increase the respiratory rate. All right, so when we're running and exercising, we are metabolizing at a higher rate. And what's being produced with metabolism? What does metabolism produce? CO2. So the more you're working out, the more metabolism you're burning, the more CO2 you are producing, right? So then the pneumotactic center say, hey, we need to pick up this respiratory rate because CO2 is starting to build too much. Let's pick up the pace. And you'll start breathing faster, okay? Because it's trying to control the amount of CO2 in the blood. So the strong signals will increase the respiratory rate and also has some weak signals that come from the pneumotactic center that prolong inspiration and increase tidal volumes. So it's kind of a checks and balances, right? Your body gets these signals from the medullary respiratory center, and the Pontine center kind of keeps everything in check. Okay, you get these inspiratory neurons and expiratory neurons from the medullary respiratory center, and then they are held in balance and checks with the Pontine centers, right? If your Pontine center is not working, then you will continue to breathe just out of whack, right? Because you got those inspiratory neurons firing, those expiratory neurons are firing, and if there's nobody there to keep it in check, it'll be running wild. That's when you start seeing all these different diseased respiratory situations, okay? So you have to have the Pontine centers there. That's why we said these different these different chain Stokes and Biops breathing. Those come from damage to the what? Brain. Pressure on that Pontine center. Pressure on that medullary respiratory center starts throwing your breathing out of whack. You can't do nothing to fix that unless you fix the brain. All right. Now, how does the pneumotactic center know when enough is enough? That is C. The Herrenbuer reflex. You're going to see that a lot, all the way up. Okay, Christian. You're going to hear that all the way up throughout your respiratory career before you take your final and your board exam. That's always on there. Herrenbuer inflation reflex. The Herrenbuer reflex is simply stretch receptors. So like the stretch marks that's on your stomach or your hips or whatever, if you have, you probably don't have none. But me, I have some. Those stretch receptors, they didn't get the message, so they kept on stretching, right? But in your lungs, that doesn't happen. Once your lungs start to stretch to a certain amount, the Herrenbuer reflex say, hey, that's enough, you're stretching me. It sends a signal to the pneumotactic center to tell the apneustic center to stop. Okay? See how the chain effect is, the domino effect? We said the apneustic center will let you breathe, but the pneumotactic center will keep you in check. And all of the signals come from the medullary respiratory center. So the medullary respiratory center sends the signals. The apneustic center allows you to take these breaths, and the pneumotactic center holds it all in check. Okay? Say it again. The medullary respiratory center sends all the signals, whether to breathe or to exhale, to the body, right? The diaphragm and all those different muscles, right? The apneustic center will allow for those inspirations, either deep, slow, fast, or whatever. And the Pontine centers, guys, hold everything in check. And they hold everything in check. One way is by those stretch receptors. Once you start blowing up a balloon, like say you're blowing up a balloon, you know when to stop, right? You can kind of just feel, if I blow one more time, this balloon gonna pop, right? So you stop, okay? Well, when you start taking a deep breath in, your lungs start to stretch, and they get to a certain point where the fibers start sending signals to say, hey, that's enough. You're doing a little too much, right? And so the stretch receptors send a signal to the pneumotactic center, and the pneumotactic center will tell the apneustic center to cut it off. See how that works? It's a chain of command. It's a chain of command. So we will be able to breathe to a certain extent until it starts to stretch. All right? Stretch receptors, they're located in the smooth muscle of the large and small airways. So the tracheobronchial tree is full of Herrenbuer stretch receptors. Okay? They're all up and down the tracheobronchial tree. It says it's in the large and small airways. They're located all down through, because the airways are just smooth muscle. The bronchioles are smooth muscle. Let's see what mine are. I'll show you. The bronchial muscles are made of they're smooth muscle. Smooth muscle. And when they start to stretch, the Herrenbuer reflex will say, hey, that's enough. You're stretching me kind of far. Once that happens, those signals are sent to the pneumotactic center to tell the apneustic center to stop. Now, how much volume is that? I mean, it's different for different people. But like it says, when it's stimulated, they send a signal via the vagus nerve to the medullary center to stop. Stop. Right? They send a signal up the vagus nerve. So the Herrenbuer reflex will send a signal up the vagus nerve to tell it to stop, to tell the body that's enough. Hey, that's enough. Up the vagus nerve. Now, how much volume is in the lungs when that happens? When those stretch receptors finally say enough is enough, about how much volume is produced? It says 800 to 1,000 mLs in an adult. Right? What's the normal tidal volume? Normal
500.
500. Good. 500 is the normal tidal volume for a normal adult. And then you just see me do this, in and out, normal in and out, just like you're doing. It's about 500 milliliters of volume. But when you take a deep breath in, right, it's the stretch receptors kick in at about 1,000. 800 to 1,000 mLs is when it starts to kick in. 800 to 1,000 mLs is when that will start to finally kick in. Okay? And so you see how that lets you take a deep breath. Because what if all you could do is 500? You would never be able to blow off enough CO2 if you was working out or whatever, right? If you needed to yarn, you couldn't yarn. You couldn't do none of that. It just imagine just breathing like you're breathing now. Right? That ain't a yarn. That wouldn't even feel good, right? So your body is allowing you to do that. That apneustic center will let you unrestrained, right? Pneumotactic center keeps it in check. And then the Herrenbuer reflex will kick in at about 1,000 mLs. It'll say, hey, bro, that's enough, right? And then it'll send a signal up the vagus nerve, up to that medullary center and say, hey, stop. Stop sending signals to breathe. You need to stop, okay? And then you stop. Now, this is what I'm talking about when I call the nerve, the smooth muscles. These are examples of the bronchial smooth muscles. Your bronchioles look like this. This would be like a real long bronchiole, right? If these were together, and it'd be, you know, one going this way, one going that way. That's how they look. These little things here, these bands, are muscles. These bands that are wrapped around the bronchioles are smooth muscle, okay? And what happens is some things cause, you're going to find out there's some diseases that cause those muscles to contract. That's what causes an asthma attack. It squeezes those bronchioles shut, and then you start hearing them sound, wheezes, right? That's what we're going into next. And we're going to take another break in a minute. We go into wheezes. When it goes down real strong, it goes into wheezes, right? Or if there's fluid or junk in the lungs, when they contract, you'll hear that, you know, those sounds are like called ronchi and coarse crackles, right? Those are the things you hear when there's fluid or mucus in the airway, okay? And so what happens is this. You start out, guys, with a normal, beautiful airway, all right? This right here will be your lamina propria, okay? This is my lamina propria. This is my muscle layer. I got muscles here, smooth muscle, right? Then the inside will be nice and pink, okay? What will be layered on here? Tell me what's layered on the inside right here. What should be there? Mucus. Mucus. And what layer is exposed to the air that's going in and out? There's two layers of mucus.
The gel layer?
The sole layer?
No, the gel layer. The sole layer would be under the gel layer, right? So the gel layer of the mucus would be right here in that pink, right? So all the air that's going through all the air that's flowing through, it picks up the gel layer will pick up all of the pieces of foreign material that make it this far and trap it so that you can cough it up, right? Well, when something happens, you have an asthma attack, these muscle bands right here constrict, and then you come to this. See that? And see how that looks convex? See how this one's pretty much flush almost, but see how concave this is? Because that muscle has contracted that bronchial, right? It contracted it. And so now it looks like this. So now you got less air going through there, like your lips, and you start to hear the what sound? Wheezes. That's wheezes because the airway has been constricted. And this right here is just extra mucus. This is mucus, right? They're just showing you that not only will it be constricted, but then if it's inflammation, it can be mucus in there too. So not only do you have constriction, but now you got mucus in the way. So you hear wheezes and you hear ronchi, like fluid going through a tube, right? You can hear that with your stethoscope. And we have medicine that you're going to get to when we talk about pharmacology. There's medicine called bronchodilators. Albuterol is the #1 bronchodilator. We give it, and then this happens. Bronchodilation. See how flat that is? So we start with this, which is normal airway. Then you have an asthma attack, and it leads to this. Right? Start out with this. You have an asthma attack, it happens to this. And then you take albuterol, and it ends up like this. Bronchodilation. Open up those smooth muscles. Will open up that, and then you can breathe again. Okay? That's what albuterol does. It's called bronchodilation. And then you no longer hear the whistling sound or the crackling sound, right? It's simple air, normal breath sound. Okay? You go from this, which is normal tone. We call it normal tone. Okay? And then we have bronchoconstriction. And then we have bronchodilation. Mm-hmm. Flovin is a steroid.
Is that the same thing that happens with bronchitis?
Bronchitis can happen. You can get this mucus build up inside of the bronchial and then becomes inflamed, right? Because itis means inflamed, and you can hear wheezing, crackles, and all that. And we have to do good hygiene, which we have airway clearance devices or things we can blow into that shake the stuff off the lungs, help them cough it up. We have different medicines that we can take to break that down, but the main thing will be a bronchodilator, which will then open that airway back up. Okay. And what was you saying? Oh, the Flovent is a steroid that will treat the inflammation, but it doesn't dilate you. Okay. It just treats the little inflammation. Yeah. If you already having an asthma attack, you don't use a steroid. Bronchodilators are what we call rescue drugs, right? That's what you want. That's why people have the little pumper in their purse. If they have asthma, you don't look for nothing else but a bronchodilator. That's what's going to instantly pop you open.
Here's one.
Huh? Oh, I can't see. Let me see. Where'd you go?
Right here.
I don't see your camera. Did you turn your camera on? Oh, I see you now. Yeah, let me pin you right quick. Yeah, see now you have ProAir, which is the trade name for albuterol. We got ProAir, we got Ventolin, Proventil. All three of those are trade names for albuterol. So when we get to pharmacology, guys, we want to talk about all those different drugs, okay, and what they do to your airway. All right, but right now let's focus on the A&P. Okay, so good. Let's see, I think that is it as far as the note-taking guide. You should have a breath sounds one in there somewhere. You might have the breath sound. Should have a breath sound one in there. Yeah, everybody should have it in there in the thing. Yeah, look around through there and see if you see the one that says the breath sound. Yep, it's got a picture of some lungs and a page that says breath sound.
In the note-taking guide?
Yeah.
Or is it something different?
It's part of the note-taking guide, right before you get to the next section. Right before you get to the next section. No biggie. If you don't, I'll try to find it and email it to everybody, but it should be in your packet.
I saw this that you put on in the.
It might even been right before.
That thing.
This is the sheet here. This sheet here. And the one that says breath sounds. Yeah. The page right after these notes. It's in my packet. It's right here. It says lesson, auscultation, and breath sound. Looks just like this. Who all online? Do you have this in your packet online?
I don't.
I'm looking, but I haven't seen it.
Okay.
Yeah, I don't have it either.
All right, no big deal. It's not a whole lot to it. But
I
I'll
don't
make
have it either.
okay. Maybe got put in some of them, didn't get put in the rest of them. That's not a big deal. But this one here, this sheet here, guys, covers the segments. What you already have the segment. It's in the book, but I just tried to make one extra. But this right here consists of the segments of the lungs. These are the lung segments. So you can take a picture of it. If you don't have it, you can take a picture of it right quick. I am recording though. My bad, hold on. Hold it up, okay.
Can you go up a little more? There you go. That's good.
Yeah, take a picture of it. All right, and then the breath sound sheet, front and back. This is the breath sound sheet. Take a picture of it and look at it. Take your picture, and then I'm going to turn it over. This is the back.
Mr. McCarthy, can you email that? Because it's just too
Yeah,
blurry.
I'm gonna email. I'm just trying to put it on for you to see later.
Oh, okay.
All right, so let's take a break. It's 3:15. Come back at 3:25. Take a break, come back at 3:25. I'm gonna talk about, you can just write notes as I'm talking though. It's not a lot, you know. I'm gonna write notes about the different types of breath sounds. I'm gonna let you hear a couple on the YouTube, which I can't record that, so I hope you're here. I'm gonna record, and then you can go on YouTube anytime and type in breath sounds and just listen to them yourself. It will behoove you to do that. The test tomorrow won't really have a lot on breath sounds, but we will do the hand washing, and I will let you listen to the breath sound mannequin we have tomorrow. So you do your little hand washing lab, and then the breath sound mannequin will be set up for those that want to go and listen to the different sounds. Okay, you can dial in whatever sound you want, and it will do it for you. Okay, but yeah, so take your break, come back at 3:25, and we will go over some of these terms and different types of breath sounds. I'm gonna try to see if I can email it to you during the break. I don't know if I have it on file. Let me see. Try to scan it to my email and then forward it over to you, if it'll work. Oh, you know what? All right, take a Adobe scan of it.
What did you say that password was to that?
Job star, JOBS star.
You said jobs. Sorry.
Mhm.
I'm gonna go on oral.
Yeah. Mm-hmm. Just a couple. All right, guys, I just sent it. You can, I'm about to pause the recording. All right, so let me go over what I gave you. Just look at the sheet and quickly talk about some breath sounds. The sheet I gave you, if you got the sheet, or the email that I sent you. All right, breath sounds. You don't have to worry about who the stethoscope was invented by, but it kind of just gives you, it's invented by Rene Laennec. Of course, it makes sounds. The diaphragm side, guys, remember, is the round side. That diaphragm side is for breath sounds and high-pitched sounds. And then the bell side is used more for the heart sounds or low-pitched sounds, okay? Of course, you always want to check it to make sure it's not waxy or cracked. The little head of it is not cracked. It amplifies the sound really, really well. So I want to make sure that it's right, because that is your tool. Your number one tool in your job is your stethoscope, all right? You have to have that stethoscope. You can't be on the floor and you don't have a stethoscope. You're going to always have to listen to breath sounds. You might have to listen to heart sounds. You might have to listen to the stomach to see if you intubated somebody in the esophagus and you're bagging, you'll hear air in the stomach, right? You know you're in the wrong place. So that's a tool that you must have. Also, if you have to take that manual blood pressure, of course, you need your stethoscope, okay? Some of them are have the double tube. Some of them are single tube. The ones that you have are the double tube, binaural, whatever they call it. Pretty good. Once you become well versed on auscultation, which auscultation means listening. Okay, auscultation. Once you start listening and hearing these same breath sounds, you can listen with a Walmart or a Walgreens stethoscope. It doesn't matter. Okay, you don't have to go out and spend $700 on a stethoscope just to listen to breath sounds. You're not going to hear nothing different than I hear. Okay, if I know what I'm listening for. All right. Now, of course, the position is important. Positioning a patient when listening to breath sounds. They should be preferably upright to allow for proper auscultation. You instruct the patient to breathe deeply through the mouth. And then this is how you start. You start in the back, posteriorly, right? That's in the back. Start at the bases and you go side to side in an upward fashion, okay? So it's kind of like this. I don't have the mannequin in here. So if I'm listening to somebody's breath sound from the back, let's just say that's their head. This is their back, right? This is their spine. Then I'm going to listen, start at the bases of the lungs. You start here, then here, here, then here, here, then here, okay? And then you may even listen up at the apices, here and here. Avoid the scapula. If I'm listening right over the scapula, I'm not going to hear anything, right? I'm not going to hear anything because it's bone right there, right? So I'm going to listen in left to right, left to right, left to right, going up. The reason why we start at the bases, guys, is because if I start at the top and you start tell them to take deep breaths, if there is some consolidation in the bases of the lungs, it might be clear by the time you get down there. So by the time you get down there, you don't hear it. And then they stop and it starts to collect again. It's something you missed. So you start at the bottom because of sheer gravity pulls the excess fluid to the bottom. So if you're listening at the bottom and you're hearing some junk, that lets you know that they're having a problem with either fluid or pneumonia or something like that, okay? But like I said, if I start up here and they breathing deep, it may clear by the time I get to the bottom, and then I missed the fact that they're having this problem, okay? So you start at the bottom and work your way up, going side to side. That's the positioning, and that's how you do it. Now, you can also listen laterally, right? After you do the back and the front or whatever, you can listen laterally, which is on the side. It says under the axilla and upward side to side. So kind of on the side, kind of like this, going up, back, right? Side to side. Axilla is the axillary, right? Which we did, V6 was 6 intercostal space, mid-axillary. That's the underarm, right? You go at the bottom, kind of go left to right just a little bit. Boom, 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 right? Listening to the sides. Very rarely do we do all of that in the hospital, okay? You really don't even listen from the bottom up in the hospital, you know, just sheer time. But in BRC, that's how you do it, okay? So when you get out there in the field and they're only starting to hear they lay a patient in the bed and through, that's usually how you do it, okay? But MBRC is going to expect you to listen to the back from the bottom, left to right, going up, okay? Make sure you do it that way for the test, all right? Now, anteriorly, same thing. Start at the basis and move upward side to side. So the basis of the lungs is about right in here. This will be the bottom. The lungs don't go way down here, right? About right up under here, right under the rib cage, right? Because under the rib cage starts the diaphragm, and the lungs sit superior to the diaphragm. So you start listening here, 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 right? Maybe up here and up here. Always avoid breast tissue in a female, right? Don't listen right over a breast. Trying to use your arm and kind of listen up under there, okay? Now, what it's saying is compare each area from one side to the next. You're comparing. So if I hear some consolidation in his lower right lobe, do I hear the same consolidation in his low left or not, right? That kind of helps me pinpoint where I'm hearing this problem, whether it's wheezes or whatever you want to see, okay? That's positioning. You look at the back. Now, we'll talk about what you're going to hear. Normal breath sounds are called vesicular. So make sure you highlight that or whatever, write it down. Vesicular is normal breath sounds. If I say a patient have vesicular breath sounds, what you going to do? Answer is nothing. That's normal, right? You may have a question like that. It says patient has, you auscultated Mr. Johnson and he noted to have vesicular breath sounds. What do you want to do? Make him cough, give him a breathing treatment, or nothing at all? Nothing at all, because they're normal. Vesicular means normal, okay? So you need to know the terminology. I don't even know if that was part of your vocabulary. It might have been, I'm not sure. All right. Vesicular breath sounds are low, gentle, rustling sound. It's a low, gentle, rustling sound, okay? Those are vesicular breath sounds. Vesicular. Vesicular breath sounds. All right, let me go. Now, I'm going to pause recording because I'm going to let you listen to some vesicular. This is the area that I will hear for Strider. We are doing breath sounds. We listen to vesicular breath sounds, which is normal. We did now we're doing adventitious, which is abnormal. And I'm stopping recording because I'm using YouTube and I can't record using their YouTube. You can go to YouTube and I will leave the link in the announcement tonight. I will put an announcement of where you can go and listen to those breath sounds, okay? But so Strider, I would listen right around in here, okay? Like that. Okay, let's go look at it. Are they? Okay, I'll check them out.
Mr. McCarthy,
Yes.
McCarthy, I forgot. I don't have, for wheezing, what were the causes besides asthma, bronchitis? Was it COPD or what was the last one?
Just you can get wheezes from any kind of. Well, I'll write it. Y'all can write it down in a minute, guys. Wheezing comes from the airways becoming very constricted. Okay. That's
okay.
And yeah, but any kind of disease that will cause any kind of airway constriction, asthma, emphysema, COPD, any kind of thing like that causes that, you'll hear wheezing. Okay.
Okay.
All right. So last thing to do, guys, is to go over a few of these oral questions, and then we're done for the day. I don't even have that many this time. These are all just, see, it's not that many in pulmonary. And even a couple of these are cardiac, okay? A couple of these are cardiac. So now I'm going to pause my recording again because I'm not going to record any of these here, okay? And I don't have anybody that's recording the screen at this time, at least that I see. I mean, it's ways around everything. It only hurt you in the end if if you're not honest, but hey, that's on you. All right, so let's look at it. We're done with the lecture for pulmonary A and P. The homework is already set into the module and will be available at 5:30. All right, at 5:30, you'll be able to post in the chat, not the chat, but post in the discussion. Once you make your initial post, and I see that you post to 2 other people, that's your credit for the day. Okay, that's your attendance for the day. But it also helps you, don't just put breath sounds are needed and I need them. You know what I mean? Make sure you make it 250 words. So, you know, you need to look in your book, your notes, and put what you learn. All right. There's no right or wrong answer. I'm not looking to take nothing off from you. I just want to make sure that you engage in it. All right. All right. So let's look at it. Put your cameras on so I can see who I'm dealing with. I'm not recording, so you don't have to worry about that. I'm stopping recording. Now, last little thing. Tomorrow, don't forget, Alpha Group, come at 2 p.m. I'll make another announcement just to anybody who's not here. I have to get my second shot for Corona, so come at 2 p.m. All right? Come at 2 p.m. All right. What are you talking about? What are you talking about? Yeah, you can't write any oral questions down. No. If you don't know it, just keep. So like what we do is as we go on, if you see it, I'm missing a lot of this group, or I'm seem to miss a lot of this group, that's when you go back yourself and start digging into that, okay? And I'm gonna start, I'm thinking about even starting to, you got the 2 teams, Alpha and Omega, might start having some competition between groups as we go on, just to help. So get together in your groups and talk to each other, whatever, you know, get you a Zoom. Zoom is free, right? Get you a Zoom and then y'all can Zoom up to 4 or 5 people, you know, in a group, and then y'all can all meet up at different times and compare notes and stuff like that. You don't have to be together. Utilize all the tools that you have. All right, so let me see. Talisha or Maria, Stephanie, everybody, if you can, I need to know, turn your camera on so I know who to ask. Because if you're not here, I don't need to waste my time asking. The people who are in the classroom, you don't have to put yours on. But everybody else, I would ask that you start your video so that we can go over a few of these questions and be through. Now, if you can't do a video, then chat me and say, I don't have video or whatever, but you can still answer the question in the chat. Maria and Stephanie, are y'all with us? All right, so I'll just go with what I got. All right, I'm going by the, I see Kelsey, Case, Cassidy, Michaelin, is that Miss, another iPhone, I'm not sure who this is. I forgot her name. What's her name? What? Huh? No, the lady. Yeah,
Miss Sydney.
Sydney, okay, I'm sorry. Okay, Sydney, I see Courtney, Christian, and Charisma. All right, here we go. Kelsey, pulmonary anatomy. Define the visceral pleura. Define tomorrow. Alpha students come at 2 o'clock. I will be here probably around 1:30ish, but come at 2. You'll take your exam, do your lab, and go home. Omega students, if you want to come around 3:30, that's fine, okay? Because you're going to get out of here quick. It's not going to be bad. But we're going to take that test, get out of here, and then the next day, we will start pulmonary mechanics. The homework for tonight is in there. I'm about to unleash. As soon as I stop this, I'm going to publish it. Okay, it's a discussion. As soon as you do your 3 posts, your posts and 2 responses, you'll have credit for today. I'm also going to open up pulmonary mechanics. So you'll go ahead and have that one open where you can kind of start looking at that stuff, get the note-taking guide off and print it off and do all that kind of stuff, okay? I'll go ahead and open that up for you as well, which is the next module, which is pulmonary mechanics, RT 210, D as in dog. Other than that, be safe. Good job. If you're posting, now don't forget, tomorrow by 6 o'clock is the last day to complete any test that you have missed. If you missed the test, tomorrow at 6 is the last time. Otherwise, it's a 0. We got to move on. All right. Good job. Everybody's beautiful faces. I appreciate it. See you tomorrow at 1.